Bismillah ar-Rahman ar-Rahim. Today I will talk about the anatomy of the larynx and clinical examination. I will start with a brief introduction about the anatomy of the larynx. A larynx in general is a midline structure, lies in front of the hypopharynx, opposite to the third and sixth cervical vertebrae. This is actually in the adult, while in the pediatric, because the larynx infant, the larynx is small, it will be higher than in the neck. So not will be in the sixth cervical, it will be in 3 and 4 cervical vertebrae. Larynx consists of skeletal framework composed of 9 cartilages. So it's a skeletal framework that means included bone. With the bone is a hyoid bone, while the cartilages, I will discuss in a minute about the cartilages. Here you have the structure of our larynx. It's composed of bone and cartilages connected together by ligament and membrane. So from inside by ligament and from outside by the membrane. Like here, this is thyroid cartilage and cricoid cartilage. We have cricothyroid ligament here and membrane. Now about the laryngeal cartilages. We have 9 cartilages mentioned before. We have unpaired cartilages and paired cartilages. The unpaired cartilages, the 3 cartilage, thyroid, cricoid, and epiglottis. The thyroid and cricoid is hyaline cartilage. Also, the arytenoid cartilage is hyaline cartilage, while the epiglottis is fibroblastic and the other is fibroblastic. We will start with thyroid cartilages. Thyroid cartilage is the largest cartilage of all. The largest of all is the thyroid cartilage. It has 2 alae or wings. Here the like right, left wings, or right alae or left alae, that meet anteriorly to form the angle. That angle here, it's acute in the males, 90 degree in the males, while the females is not acute, it will be 120 degree. So if it's acute in the males and more projection lead to prominence of that Adam apples. So Adam apples is because of the acute angle of the thyroid cartilage. While the cricoid cartilage is the only complete cartilage of the larynx, so it's complete, and the thicker and stronger one. The thicker and the stronger one is the cricoid cartilage, and its anterior, it's narrow, while the posterior of the cricoid cartilage is broad. After that, here you have the cricoid cartilage. This is the thyroid, and here the cricoid cartilage. Okay. Then we will go to the epiglottis. Here maybe it's not present, but I will show you in a minute. The epiglottis cartilage is a leaf-like structure arise behind the tongue. So epiglottis is a leaf-like structure arise from the tongue. Then the paired cartilages, we have the arytenoid cartilages is 2. So we have, this is the arytenoid cartilages is posterior. Here the right arytenoid, while here the left arytenoid. It's pyramidal in shape. It has apex and base. The apex of the arytenoid attached to the other cartilages, the corniculate cartilage. So the corniculate cartilage is here. Here you have the corniculate cartilage attached to the apex of the arytenoid cartilage. While the cuneiform cartilage is actually within the airy epiglottic fold. So inside the airy epiglottic fold, I will show you in a minute where it's present. Sometimes you found that small cartilages is called tracheous cartilage and found in the thyrohyoid ligament, may be mistaken on the X-ray as a foreign body. Any question on the cartilages?
Cleared. واضح.
دكتور
Okay. Yes.
بس في سؤال على الكريكويد. قبل شوي
Yes.
تقول انه it's the only complete cartilage.
Yes. Yes.
ايش المقصد يعني؟
It's actually that mean complete. That mean it's you cannot see any space from posterior. Like see the thyroid is not connected posterior together. It has space, while the cricoid is connected. Okay.
تمام واضح.
Yeah, like a ring. Okay, it's not is complete, so it's not incomplete by the space. That's what I mean.
دكتور
Okay. Yes.
ممكن ترجع السلايدات؟
Okay.
انا ما فهمت بس كيف البيس والابكس حق الريتينويد، يعني هل هي
Yeah. Look for the shape of the arytenoid, like a pyramid. Okay.
حلو.
Okay. This is the apex of the pyramid, and here you have the base of the pyramid. Okay. The apex articulate
يعني
with the
دكتور موجه على
chronic.
تحت يعني يصير عكس.
Yes. Is a pyramid in shape. Okay. هرم الشكل مثل الهرم.
وضحت. شكرا.
Okay. Here the picture, the endoscopic picture of the normal larynx. You are looking from the up, okay? Here the epiglottis is the leaf structure, anterior. Here you have the tongue. So you are looking for the patient from anterior. So this will be the right focal cord, and here will be the left focal cord. How can I know this is the right or left focal cord? First, epiglottis will be anterior of the patient, so anterior. And the arytenoid is posterior. It will not be anterior. So you are looking for the patient from here. Okay, so this is the right focal cord, left focal cord. Other different, the focal cord itself actually is attached to the middle of the thyroid cartilages. So it form here the area of narrow, is not having gap here or angle here. So that means this is anterior. It called this area anterior commissure, while this area posterior commissure. Posterior commissure, if you have gap, that means posterior, not anterior, like here. So this is right focal cord and this is left focal cord. We will have it exercise on the other lecture for the right and left focal cord. And here you have posterior, the opening of esophageal inlet. So if you have food from here, that lead to epiglottis to close the airway and the food pass to the esophagus. Okay. The area of cuneiform cartilage is within this is the arytenoid and the epiglottis, the area epiglottic fold. Here you have the area epiglottic fold. Within that, the cuneiform cartilage is there. Okay. Here you have the larynx, the cartilages, while the bones. Here you have the hyoid bone, and here you have the thyroid cartilages. Here you have the epiglottis, the cricoid cartilage. Other cartilages inside, like here, the more clear the pyramidal in shape. Okay, this is more clear here. This is the arytenoid. At the apex of that is attached the corniculate cartilages. Just very important detail on the arytenoid. It has two processes: focal process and muscular process. The focal process attached to the focal ligament, focal fold attached to the focal fold. You have focal fold here and focal fold here. So that attached to the focal ligament is the focal process, while the muscle to the muscle, like cricioarytenoid muscle and other muscle. So it has two processes: focal process, muscular process. From the posterior here, more clear the shape of arytenoid and corniculate as well. I will not go about even more details about that, but here you have the cricoid cartilages. It's broad from posterior and narrow anterior, and it's complete. It's complete ring. Just more details on that, just to see picture and more understand the area of the thyroid cartilage, and here the angle if it acute leading to the Adam apples, and here you have the cricoid cartilages, arytenoid, corniculate, epiglottis cartilages. I will not go in detail on that. Just more understand. Any question on the cartilages? And
It's clear, doctor.
okay.
Thank you.
Now we will go to the muscles of that. We have actually three types of muscle. It can be abductor muscle, adductor, and tensor muscle. Adductor muscle, the only muscle which is the most important muscle of the larynx is posterior cricoarytenoid muscle, supplied by recurrent laryngeal nerve. All the larynx is supplied by the vagus nerve, and its branches, the recurrent and superior laryngeal nerve. Adductor, lateral cricoarytenoid, thyroarytenoid, and cricothyroid, which is actually external branch of superior laryngeal nerve. It's included to the adductor as well as cricothyroid to the tensor, the tensor of the tension of the larynx itself. Adductor, what the aim of that? You know, abductor, it's away from the midline, while adductor toward the midline. Only muscle that move the larynx away from the midline is posterior cricoarytenoid. Here you have the muscles, the posterior cricoarytenoid muscles. So it's from its name, posterior. Lateral arytenoid, that means the lateral of the larynx. Posterior, that means posterior to the larynx. And here you have the posterior cricoarytenoid and transfer arytenoid muscles. The arytenoid, it has oblique transfer. Further detail, I will not go in detail in that. And you have here the cricothyroid muscle. It has two branches, a vertical part and oblique part, leading to the tension of the abductor and tension of the larynx. Here you have the posterior cricoarytenoid muscles. It's from posterior. If moved, leading to the opening of the, that means abductor, that means opening of the vocal cord. And here you have the lateral arytenoid and muscles and others. We'll not go in detail, just to understand that. But any question on the muscles before going to the clinical division? Okay. Okay, very nice, very nice. The larynx, it has a clinical subdivision. The aim of that, why it has the disease itself, the types of, even if stridor for the patient, he has noisy breathing, any obstruction leading to the noisy breathing, that even mention you are in the which area. And the subdivision is actually supraglottic, glottic, subglottic. So it's three division. Supraglottic, from the tip of the epiglottis to the floor of laryngeal ventricle. I will show you in the picture. While the glottic, from the floor of laryngeal ventricle, not only 1 centimeter inferior, so below the focal fold, 1 centimeter, still you are in the glottic area. Start from 1 centimeter below the focal cord is the subglottic till the inferior border of cricoid cartilage. So the larynx division from the tip, mainly from the tip of epiglottis till the inferior border of cricoid. After the cricoid, start the trachea. I will show you here more clear for that. So this is the supraglottic from the tip of epiglottis till the ventricle. If you have elliptical, that space, this is the ventricle. Till that it's supraglottic. From this area, 1 centimeter below the focal cord, here you have the focal fold. 1 centimeter below the focal cord is glottic area. From 1 centimeter below till the inferior border, this is the cricoid cartilage, till the inferior border of the cricoid cartilage is the subglottic. Okay, and the narrow part actually in the larynx is infant, and that is subglottic area. It's a narrow part. Here you have more colorful purple color supraglottic, while the green is glottic, and the subglottic is the pink one. This is the more clear for the vision. Is it clear the division, clinical division of the larynx?
Clear, doctor.
Yeah, clear.
Okay, the other difference, the other also difference about the supraglottic, even the tumor itself, it has staging. So supraglottic, it has TNM staging. By the tumor, you will have TNM staging. That means size of the tumor, lymph node, or distant metastasis. So it has different staging. Supraglottic tumor, not like focal cord tumor, not like subglottic tumor. It has some difference in that as well. Here you have the laryngeal innervation. It's mainly by the vagus nerve, and it's two branches, the recurrent and superior laryngeal nerve. Here you have the superior laryngeal nerve, and here you have the recurrent laryngeal nerve. More clear in the picture here, the difference of that, and then we'll go to the details. So the nerve supply of the larynx, it's by motor and sensory. The motor, actually all the muscles supplied by, in general, supplied by recurrent laryngeal nerve, except the cricothyroid muscle, which supplied by superior laryngeal nerve, the external branch of superior laryngeal nerve. So all the muscle by recurrent, the motor movement, while the sensory, it has difference. Above the focal cord is supplied by laryngeal nerve, internal laryngeal nerve, that means superior laryngeal nerve. Below the focal cord and below the focal cord is supplied by recurrent laryngeal nerve. So it has two divisions. Above the focal cord is supplied by the superior laryngeal nerve, below that supplied by recurrent laryngeal nerve. Now we have the recurrent left and right. I will not ask you about the courses, okay? To memorize the courses from where going ascent, and maybe you will know it clear from the anatomy, but we will not ask about the courses, but just to understand the course, long course of the recurrent laryngeal nerve, the left one lead to more prone to the paralysis, but just brief that it arises from the subclavian arteries, hooks around the right, and ascend between the trachea and the esophagus, while the left at the mediastinum, at the level of the arch aorta, so deep. That means below the right, and then goes ascend to enter the larynx. Superior laryngeal nerve, it arises from the inferior ganglion of the vagus nerve, behind the internal carotid arteries and hyoid, and the main artery actually supply the supraglottic for the sensory, and the motor part for the cricothyroid muscles. Let's enter the larynx through the thyrohyoid membrane and do the sensory innervation of the larynx as well as hypopharynx, because above the larynx is the posterior larynx is the hypopharynx. Any question in the nerve supply of the larynx? Yes, Abdullah?
Superior laryngeal nerve, doctor. Is it the same as external laryngeal nerve?
Superior laryngeal nerve, it has two branches, external and internal. Okay. So the father of the external and internal, the superior laryngeal nerve. The father of the superior laryngeal nerve is the vagus nerve. So it's the superior laryngeal nerve, it has two parts. The external supply the cricothyroid. The internal supply the larynx by the sensory innervation, sensation.
Clear, doctor. Thank you.
That's good, okay. Now again, just to know the movement of the larynx when the contraction of the posterior cricoretinoid leading to the open of the focal cord. This is the action of the cricoretinoid. So it's away from the midline. Here you have the midline, mission midline. This is the midline. Sometimes if it's para to the midline, it's called para midline, especially if the palsy paralysis, it's para median. I will just mention that just to understand that from the beginning. So it leads to abduction of the focal ligament. Again, the same of the if it's action of the lateral cricoretinoid muscle of the lateral, that contraction lead to closure of the focal cord. Now about the histology of the focal cord, especially, mean a focal cord at the level of the layers of the focal cord. We have the mucosal layer of the focal cord. It's pseudo-stratified squamous epithelium, superior and inferior, while non-keratinized squamous epithelium at the contact surface of the medial cord. So at the focal cord is squamous epithelium, while above the focal cord and below it's respiratory epithelium or pseudo-stratified squamous epithelium. So it has two epithelia, the squamous while the pseudo-stratified squamous. But the position of that, the squamous at the level of the focal cord. Above that, below that is the pseudo-stratified squamous epithelium. So we have mucosal layer, subepithelial tissue, the other layer, but it has a three-layered lamina propria. We have superficial layer, intermediate layer, and deep layer of the lamina propria. So we have the mucosal layer, then lamina propria, we have the superficial layer, it's called larynx space, the other name is larynx space. We will have it in dysphonia, like edema there. We have the intermediate layer, deep layer of lamina propria. The intermediate and deep make the focal ligament. We mentioned the focal ligament. It actually consists of two layers, the intermediate layer of lamina propria and deep layer, while the last layer is focalis and thyroarytenoid muscle. So all the layer are actually leading to that movement of the focal cord and more protection of the focal fold and for our larynx. More clear, don't worry. Here again, the squamous epithelium, focal fold layer, from the superficial to the deep, we have squamous epithelium, non-keratinized stratified, superficial lamina propria, intermediate lamina propria, deep lamina propria, and the last layer is thyroarytenoid muscle, called thyroarytenoid muscle. The intermediate and deep form the focal ligament. Laryngeal joint is a cricothyroid joint and the cricoarytenoid joint. So we have joint between the crico and thyroid. So cricothyroid joint, and between the crico and arytenoid, it's called the cricoarytenoid joint, that leading to movement of the larynx. Actually, the larynx in general, it moves with, when we are actually swallowing the food, it's moves vertically, it goes up while swallowing the food. So it can leading to that movement. All these layer protection, muscles, cartilage, leading to protection of the important structure larynx. Here again, the layer of the yellow one is actually the squamous epithelium. So at the level of the focal cord, we don't have pseudostratified. It's called squamous epithelium. Above that and below that, it's pseudostratified squamous epithelium. Then we have basement membrane or superficial lamina propria. You have superficial lamina propria. Its other name of superficial lamina propria is the larynx space. So when we mention rhinic space, that means we are dealing with superficial lamina propria. While after that, the intermediate layer, then the deep layer, and both form the focal ligament, and then the focals muscle or thyroarytenoid muscles. Here you have the airway passing from here. Any questions so far for the focal fold layer and the anatomy before going to the physiology? Okay. Now we'll go to the physiology of the larynx. I hope that brief anatomy is. I will not go further detail on the anatomy because this is a clinical course. The main action of this course is to know clinically and how you can apply the anatomy during you are facing the patient during the surgery to know which important structure and how you can deal with that. Physiology of the larynx. The function of the larynx, we have airway protection. It's the important function of the larynx. Breathing, because the air comes from the larynx. Voice production or phonation. Increase intrathoracic pressure. Airway protection, we have three ways of protection. All the sphincter of the laryngeal opening, like a focal cord, epiglottis, and other, even the false focal fold, which is vestibular fold we mentioned. I will again, maybe I will go back to see that false focal cord, cessation of respiration, and cuff reflex. So the even stop of respiration leading to protection. Also, if you have any aspiration only leading to the cuff reflex, so airway protection. Increase intrathoracic pressure, actually done by fixation of chest by glottic closure. Glottic closure leading to fixation of chest, essential when you actually straining and climbing. During straining and climbing, you need your glottic closure to fixation of the chest and leading to very important for the function of that activity. Phonation, it's a physical act of sound production, leading by means of passive focal fold interaction with the exhaled airstream. You have the exhaled airstream, air coming from down, leading to interaction of the focal cord. That interaction of the focal cord leading to vibration. Vibration making that sound. So during phonation, actually the focal cord kept abducted, closed. Then opening by the air from down, leading to vibration of the focal cord. That vibration leading to that sound. That sound is amplified by the nose, our nose, mouth, our pharynx, also the chest. So when the air comes down, leading to interaction of the focal cord, that interaction, the sound production, vibration, amplification by the pharynx, mouth, and the nose, leading to that speech and sound. In a simple way, okay? Here you have again, this is the opening of the larynx, while closure of the larynx, leading small opening by the air. That small opening here, leading to vibration. That vibration leading to the sound. That sound amplified by we have the mouth, nose, and pharynx, leading to amplification of that sound. Here you have we have mentioned that true focal cord, and maybe we mentioned about true focal cord, they have false focal cord. The simple way, true focal cord is the whitish one, is the true focal cord, while the other is like focal cord, is a shape like focal cord, but it's called false focal cord or vestibular fold. Other name of that, the false focal cord, is vestibular fold. So the focal cord is a part of the glottic, while the false focal cord is a part of supraglottic. Like here, maybe more clear, this is the whitish, this is the focal cord, while symbol-like shape, this is the vestibular fold, or the other name is a false focal cord. Here the anterior Y, here we have the base of the tongue, here you have actually the part of the epiglottis, and here you have the arytenoid. So this is, we are dealing with the posterior, anterior, so this is will be a right focal cord, this is from the left focal cord. Is it clear the true and false focal cord? So for the focal cord, we have true focal cord, which actually means when we are mentioning focal fold or focal cord, that means we are meaning the true focal cord. But we are mentioning, if we are mentioning the false focal cord, not necessarily the true, is actually the other name is vestibular fold because of the vestibule. This is the false, this is the true focal cord. Why they are not confusing about the, not making the confusion about the focal cord, is it false or true, but the structure looks the same, but the color and even the location is not the same. Any question on the anatomy and the physiology? Physiology, I mean.
Clear, doctor.
Clear, doctor.
Okay, thank you everyone. I will show now how you are approach or examine the larynx, clinical examination of larynx. Actually, for evaluation, patient of the larynx, you need to do history taking first. We mentioned in the second lecture, but here the examination, you will do complete head and neck examination, including the cranial nerve. So, you are mentioning any kind of examination, larynx, even nose, I will do complete head and neck examination, including the cranial nerve. Why cranial nerve? Because we are thinking about other affected nerves. Laryngoscope, how we can, it can be indirect or direct. This examination, specific examination of the larynx, laryngoscope. It can be indirect by using laryngeal mirror, passing through the mouth and looking down to the larynx, or direct by flexible fiber optic or rigid scope. So we can see direct by flexible or by rigid. And then we examine all the area. If you have any concern about the structure or other abnormality, the gold standard of laryngeal and tracheal evaluation, and going down, is rigid endoscope under general anesthesia. If you want better evaluation of the larynx, it's better, or airway management, the goal is do rigid endoscope, bronchoscope, even pass through the larynx, going down to the trachea and look for have any kind of airway problem. Here the laryngeal mirror, advantage is fast, passing through the mouth, looking down, inexpensive, minimal equipment. Disadvantage, maybe you can initiate the gag reflex, non-physiological, because you are holding the tongue of the patient by your hand and see by the mirror, and it will not like physiological and even no permanent image capability. Now we have in the clinic, actually they have availability of the endoscope, the fiber optic and rigid. Actually rarely we are using this mirror nowadays because we have the availability of the endoscope. So you are looking the mirror, what you are look, focal cord, and ask the patient to say E to see the mobility of the focal cord. Look for any abnormality like polyp, nodule, any ulcer, mass, movement of the focal cord, cancer. I will show you in the second lecture about another abnormality, but you are looking for the normal structure. If you have any abnormal finding, you need to pick that. The rigid endoscope, we have rigid endoscope. It can be 70, 90-degree telescope. We will have it in details on the clinic about examination of the larynx and how even to do examination the larynx in the clinic, in the clinical teaching. Okay, don't worry about that. But better to know the advantage and disadvantage of rigid, while the advantage of disadvantage to the flexible one. To know here you have the rigid. So rigid endoscope, 70 degree, 90 degree. I mean the angle of that. 70 degree, that means looking, the angle is looking up. 70 degree, the picture it will be. So we have 0-degree scope, that means straight looking for that. Don't worry about that, we will have it in the clinic, but I need something to look down. Why 70 and 90 degree? Because I want to look down, not look in front of me. So I need something is angled to see down the larynx. It's this optic image. It can magnify the focal cord and video documentation. For that, you can connect it to video, look for the patient, ask him to do EE, and to look for mobility of the focal cord if he has any abnormality or immobile or paralysis of one focal cord. The disadvantage can be gag reflex because you are going from the mouth. The rigid endoscope, you are going from the mouth. Non-physiological, because like the mirror, you will hold the patient tongue, and expensive, not like the other mirror and other. Here you have the flexible one. Flexible. Here you have the flexible one. It's actually fiber optic nasolaryngoscope. So we will not pass from the mouth. You are passing from the nose, going down to the larynx. The advantage, you will tolerate it for the patient, physiological and video documentation. Disadvantage, time, expensive like rigid endoscope. But resolution limited by fiber optic, so less resolution rather than the rigid. Rigid is better resolution than the fiber optic. Okay, I will show in the picture. Maybe you will have it here. Here you have the fiber optic, so we will connect it to the monitor and to pass it through the nose of the patient, going down to see the larynx. Okay, so you're passing here and going down to see the larynx. While the rigid endoscope, you are pass the rigid through the mouth and looking down to the larynx to see any kind of normal structure and the abnormal structure. Any question on the clinical examination of the larynx? We have only 2 slides. Yes, Abdullah.
في سؤال بالنسبه للفسيولوجيكال، وش اقصد بالضبط لما نقول هذا فسيولوجيكال وهذا non physiological؟
Physiological, that a patient he will not tolerate any kind of function of his function, so will not stop any function just to see his function. Like physiological, I will pass the fiber optic, so I will not hold the tongue. I will not mimic the function of the patient. Okay. While the rigid, I will hold the tongue and mimic the function of the tongue, leading to it will be non-physiological. Okay. Not interfere with any kind of the function of the patient. Okay, Gila, is it clear for you?
كثير دكتور النقطة هذه، بس في سؤال ثاني دكتور.
اوكي.
بالنسبة لل 90 degree، هل رأس البيشنت ولا نفس الصورة في 90 degree؟
لا, there will be the picture.
بس.
The picture will be 90 degree. It will be the angle. Either up or down, you will see the picture, okay? Not in front of you. You will show it in the clinic, don't worry, to see it, the 70-degree scope and to look how to handle that and even we'll pass it through the mouth and to see the structure, normal structure of the vocal cord. Here we have the direct laryngoscope. Here you have the laryngoscope available for use with the treatment. When you are using with the treatment like microlaryngeal surgery, any kind of surgery to the larynx, you can use the direct laryngoscope. Direct laryngoscope, that means you will pass to the larynx to look for here. You are looking from here to see the larynx here, and you can do what kind of operation you will do. Thank you. If you have any question, you are welcome. Any question?
It's all clear, doctor. Just one small thing. When you talked about direct laryngoscopy, you said it could be used with treatment.
Yes, you mean the last one?
ايه تقدر توضحها شوي؟
Direct laryngoscope, that means you are passing, this is called laryngoscope. Direct, you are looking the larynx directly. Not like in mirror, indirect.
Okay.
Yeah, you are looking this, the larynx now in front of you. You are passing through till you are seeing the larynx, okay? In front of you, not indirect. Like a mirror. A mirror, you are looking down to see the mirror for that.
الميرور اللي عندنا اللي هو الريجيد والنون ريجيد صح دكتور؟
لا الميرور again just to see looking again about the mirror here. This is the mirror, okay? Laryngeal mirror. It's called laryngeal mirror. Here you have the mirror. You are looking for down. You are looking for the mirror, but it's the picture will be upside down to look for the larynx. So indirect, not direct. You are looking now front.
إذا جينا نتكلم عن دايركت هي اللي تكون ريجيد ونون ريجيد.
يا سلام عليك. ريجيد and الفلكسبل.
إيه الفايبر أوبتيك.
يعني all are direct except the mirror is indirect, okay? Previous slide. Here you have the mirror. Again, you are looking here and to look the larynx indirectly to look for the larynx. So you are not in the larynx. You are here looking for the larynx from up. Okay, thank you all. I will just stop. Now, let's stop recording here. I will stop recording.